show you certain questions, and from the questions I'll tell exactly how it proceeds. So this is a very simple question, and this question basically type A question that will come to you. And the question is, definition of AKI does not include. So that means, see, AKI is acute kidney injury, very nascent term. It's a new terminology that is the terminology of this century. Before this, it was known as acute renal failure. We all have passed our examination telling it as acute renal failure. But the terminology is new, the definition is new, the diagnosis slowly is becoming newer and newer. From its static diagnosis, now we are moving towards a dynamic diagnosis of AKI. So the whole paradigm is changing. And whatever we are seeing today might change in a couple of years. But you should know everything which is going on in AKI today, and you will get a lot of questions. You'll get a lot of questions because this is an evolving science. A new thing is coming up. For example, and this is applicable for every chapter in intensive care. You have to know the evidence. EDIC is basically European Diploma Intensive Care. It is basically an evidence-based diploma in intensive care. If you do not know the evidence, do not know the latest papers that are coming out, and they give question from those papers, they quote also. So that is the reason why you have to be very much attentive in reading the New England Journal, and especially the ESICM, that is the European Society's Journal. So ICM. So for example, you get a question, definition of AKI does not include. It does not include which one? Increase in serum creatinine by 0.3 milligram per DL within 48 hours. Increase in serum creatinine by 1.5 times the baselines, which is known or presumed to have occurred in the prior 7 days. Urine volume less than 0.5 ml per kg per hour for 6 hours. Or an increase in serum creatinine by 0.3 milligram per DL within 72 hours. Now, everything seems to be a definition of the AKI. But if I go to the definition which is followed today, next slide, we'll find that, next slide please. We'll find that AKI is defined, this is the KDIGO definition, this is still going on nowadays, and we are following this definition. Increase in serum creatinine by 0.3 milligram per DL within 24 hours. See, as in micromole per liter also given, so you might get a question also in micromole per liter. You don't know what is going to happen. So, or 1.5 times the baseline. The first one is within 48 hours. 1.5 times the baseline is presumed to have occurred within 7 days, and urine volume less than 0.5 ml per kg per hour for 6 hours. So this is the definition. So there is nothing called 72 hours in the definition. So that you have to exclude. This is a very simple question that I have started with. Now when you qualify the definition, the questions come up and they become more difficult. So the next slide, please. I will show you a question on the classification of AKI now. Now, since 2004, acute kidney injury has been classified. This was the first classification given by Rifle. Risk, injury, failure. The last one is the end stage renal disease. So if you don't know exactly what is the basically the your terminology, then you will basically not know exactly what this classification is: risk, injury, failure, loss, and end stage renal disease. So now the question comes like this. Let's see. E represents early renal disease. Obviously, E doesn't represent, it is the end stage renal disease. So this is false. Kidney failure can be diagnosed by urine output alone. Now, if you don't know the classification, you don't know this answer. So we will go to the classification. So yes, it can be diagnosed by urine output alone because it has either the creatinine or the GFR on one hand and urine output on the other hand. Criteria for risk of the risk part is highly specific. Now, in the initial stage of Rifle, that is the risk part, it is highly sensitive. Whereas the failure part definition is highly specific. So if you have not seen that table, you will not be able to answer this question. So the criteria for risk, the risk factor, that is the R, is highly sensitive, not specific. So this is a false answer. And serum creatinine is accepted as an index of glomerular function. Definitely, it's a functional biomarker, serum creatinine. So it is accepted as an index of biomarker. This is a typical EDIC question, K-type question that comes and that I have taken up so that you can understand exactly how the question comes. Next slide, please. Now see the rifle criteria. If you see the rifle criteria, you will see that the risk, injury, failure, loss, and end-stage renal disease is coming. This is in, and if you see here, urine output criteria and the serum creatinine criteria is going side by side, 1.5 times the baseline by increasing from 1.5 times from the base value is the risk, 2 times is injury, and 3 times is failure. But GFR decrease more than 25, more than 50, and more than 75, or a rise in creatinine more than 4 milligram per 100 ml, and an acute rise of 0.5 milligram per 100 ml per. This is also very important as a criteria in the failure part. Urine output 0.5 ml per kg for 6 hours, 0.5 ml per kg for 12 hours, and less than 0.3 ml per kg for 24 hours, or anuria for 12 hours. This is the criteria for urine output. So see here, if you add, what is loss? Persistent ARF, complete loss of renal function for more than 4 weeks, and obviously end-stage renal disease when the GFR is going below 15 ml per minute. So this is the situation of rifle criteria. You can get a question. Still, rifle is valid in different parts of the world. This has been validated in many ICUs. So rifle criteria can come as a question anytime when you are seeing the acute kidney injury, its definition of acute kidney injury. So this criteria was followed by another criteria that is known as the 𝒂𝒃 criteria. So next slide, please. So let me come to a very generalized question before coming to the 𝒂𝒃 criteria. So you can get a question like this regarding AKI in ICU. Now this is basically more or less a bit of etiology, a bit of treatment. They can mix the question. And hypovolemia is the commonest cause of AKI in ICU. Now see, what do you think? Is hypovolemia the commonest cause of AKI? Hypovolemia is not the commonest cause. Commonest cause is sepsis. Sepsis is the commonest cause. So this is a false answer. Similarly, mortality is not. Now this is the second one is a bit of common sense. You may not be knowing, but mortality is not significantly different between ICU patients with or without AKI. This is false. Those patients who are with AKI, with another organ function dysfunction, will have more mortality. The mortality is very high. It goes up to 70 to 80%. So you have to know about the percentage also. The prevalence of RRT in ICU is about 65%. This is not the prevalence of RRT. The patients who are having RRT is hardly 10 to 15% in the ICU. And you just think about, if you are working in an ICU, you will see how many of your patients goes into RRT. If you see that, you will see it is somewhere between 10 to 15%, somewhere it is 20%, but it cannot be 65%. And the vast majority of the patients are dialysis dependent. See, this is the difference. Here, they have given 86% of the survivors are dialysis dependent. Had it been a question in 2008, this is the right answer, because one study that came up in 2007 showed there's a huge number of patients are RRT dependent. But the question now in 2023, only 28 to 29% patients are RRT dependent. The latest one, that is covers a meta-analysis in Nature, and they have shown that the dialysis dependence has decreased vastly due to better treatment options, due to fast knowledge about AKI, prevention of AKI. So dialysis dependence has come down drastically over the last decade. So this question in 2008, the last one would have been true. But today, this is false. So this is the way how EDIC evolves. So you should be knowing about the latest questions, then only you can answer the questions. All right. The latest developments, every day you go through the newer things that are coming up. The next slide, please. Next slide. So see the rifle criteria, but details on the rifle criteria. So allows identification of significant proportion of AKI patients who are hospitalized in numerous settings and enables monitoring of AKI severity. That means the question is, it is validated in the IC. It has been already validated in large studies in different type of ICUs. So it can be applied in most of the types of ICUs. That is basically the question might come like that. Now the second is good predictor of patient outcome. So the question might come as whether it is a good predictor of patient outcome or yes, it is good predictor. It did not aim to trigger standardized therapeutic intervention. This is very important. And it did not aim to predict mortality or adverse outcomes. So it is not there to predict mortality or adverse outcomes and did not aim to trigger standardized therapeutic intervention. They may come as a question. So next slide, please. Next slide. So now after rifle criteria in 2007, the 𝒂𝒃 criteria came up. What the 𝒂𝒃 did, it removed GFR from its criteria. It included a very small rise in creatinine. It basically 𝒂𝒃 sensitized us more with acute kidney injury. Here it was 0.3 milligram per dl increase in serum creatinine also was considered to be significant in 𝒂𝒃 criteria. So this is the first stage. And here the loss and the end stage renal disease was removed. Only 3 stages were kept. Serum creatinine and urine output, both criteria were there. And here the last one, they have added treatment with renal replacement therapy. That is also stage 3. So 𝒂𝒃 criteria included the treatment option as one of its stages. So you may get a question that the acute stage 3, a patient who is on renal replacement therapy is in acute stage 1. They may give. This is false. Acute stage 2, it is false. Acute stage 3 is right. Because treatment with renal replacement therapy is in stage 3. So GFR criteria removed, rifle loss removed, loss and end stage renal disease removed. And the most important point of this one, apart from 0.3 milligram per dl, is a 48-hour time frame within which the diagnosis of AKI must be met to fulfill 𝒂𝒃 criteria. So that is another question that may come. So they will again can give questions on 𝒂𝒃 criteria. It is very much there. It has been validated in many ICUs. So question may come from 𝒂𝒃 also. Now what in 2012 happened? In 2005, 4 and 5 this rifle came. 2007 𝒂𝒃 came. 2012 basically KDIGO was very smart. KDIGO basically combined these two, rifle and 𝒂𝒃 criteria, and took out the KDIGO criteria. Next slide. Next slide. Yes. So in the KDIGO criteria, I've given the diagnostic part that I have already told you, and you see the pyramids are showing again the two outcomes has been taken: serum creatinine and urine volume. The same thing in urine volume, not much of change. But in the 4th stage, go to the next slide, please. Next slide. Yes. So the 3rd stage, here you see, there is for children, exception of children of 80 days, acute decrease in eGFR to less than 35 ml per minute per 1.72 meter square is the criteria for stage 3 AKI. So this is the thing that has been taken in children, and they might be asking you this particular aberration that has been taken up by KDIGO. So these small changes are asked in EDIC. So they might ask this question to you. The next question, next one, please. So regarding rifle, 𝒂𝒃 and KDIGO, which statements are more appropriate? Now what they have done, they have basically compared all these 3 in different studies, and this is the latest basically assimilation of all this study. And what they say, whether KDIGO is superior to rifle in diagnosing AKI and predicting early and late mortality. So this is a true one. So KDIGO has a higher incidence of AKI than both rifle and 𝒂𝒃. If I use the KDIGO, they have seen that maybe the incidence of AKI is diagnosed much higher than rifle and 𝒂𝒃. KDIGO is more predictive than 𝒂𝒃, but not rifle in evaluating in hospital mortality. Just opposite. KDIGO is more predictive than rifle, but not 𝒂𝒃 in evaluating hospital mortality. And prognostic ability is same as 𝒂𝒃 and rifle. Obviously, prognostic ability of KDIGO is much better than 𝒂𝒃 and rifle. So basically, the last two are wrong. So you must be knowing that KDIGO is superior to rifle in diagnosing, higher incidence of AKI in diagnosis from both, more predictive than rifle, but not 𝒂𝒃. So the in-hospital mortality is same for 𝒂𝒃 and KDIGO, and prognostic ability is always better with KDIGO than that of rifle and 𝒂𝒃. Next slide. So I have just shown you exactly these are the studies from which the question has been given. So that has been reflected in the question. These are the studies which are basically the evidence on which this question has been made. So the questions are made on evidence, and they are not basically suddenly selected. So this is the way how you go on reading about EDIC. Next slide. So whenever you study about AKI, you must be knowing about two other definitions. One is your AKD, that is your acute kidney disease, and CKD. See, AKI, the definition is up to 7 days. Now, what about the patients who are going beyond 7 days? So they, from 7 days to 30 days, to 3 months. So this is the stage of AKD, that is acute kidney disease. What is NKD? No kidney disease. AKI, acute kidney disease. AKI, acute kidney injury. AKD, acute kidney disease. And CKD is chronic kidney disease. Whenever after 3 months, you have certain loss of GFR less than 60 ml per minute for more than 3 months with some amount of structural kidney damage. So some structural kidney damage, the moment it is coming, it becomes CKD. And if the kidney damage is less than 3 months, you have not got any structural changes, but this AKI is continuing, or GFR is less than 60, or decrease in GFR more than 35%, or increase in serum creatinine by 50% for less than 3 months. This is the definition of AKD. So you can get a question on AKI, AKD, and CKD as questions, but you have to know about the definitions. So I thought that I should show this slide to you. Next one. Now, once you have gone through the diagnosis, through the definition of AKI, now they will basically still they are asking these questions. So I'm giving a bit of importance to them. Exactly. Sometimes the question might come as acute kidney injury or acute renal failure, because the diagnosis that was this diagnostic criteria that was given pre-AKI stage, pre-AKI era, where these fractional excretions of sodium, urea were seen. So the basic question that may come, that how can you diagnose pre-renal acute renal failure? By seeing the fractional excretion of sodium, which is the most sensitive and specific marker, less than 1%. So this is the answer. If the fractional excretion of sodium is less than 1%, it is a pre-renal. More than 1%, it's renal. Next question. Now, slowly they are increasing the level of the question. See the level of the question, you might not get the previous question because everybody knows it. Now the question what they have given. The following values indicate pre-renal acute renal failure in presence of diuretics. So in presence of diuretics, fractional excretion of sodium doesn't hold good, because diuretics also excrete a lot of sodium into it. What it doesn't excrete is urea. So that is the reason here the fractional excretion of urea has been taken as a surrogate marker of pre-renal acute renal failure, not fractional excretion of sodium. Less than 35%, that means it is pre-renal. More than 50%, it becomes renal. So that means you must be knowing this. Otherwise, you will miss this question. Next one. Now see, it is a very beautiful question. Now the level of question is increasing. All right, I am showing you how it is increasing. You may get an easy question. You 1 or 2 easy questions, but you can get a difficult question like this. A patient of cirrhosis comes with altered sensory. So whenever you think of cirrhosis and the acute kidney injury, the first thing that strikes in your mind is what? Anybody? All right. Hepatorenal syndrome. Hepatorenal syndrome. So hepatorenal syndrome. The moment you see the question cirrhosis with comorbid altered sensory, we don't have any time. Hepatorenal syndrome है, लगाओ C. Answer लगा के निकल पड़ा. But see the question that they have given. The urinary parameters are as follow. Fractional excretion sodium is less than 1%. Fractional excretion of urea is less than 25%. In hepatorenal syndrome also, excretion of sodium is less than 1%. Excretion of urea is less than 25%. Creatinine urea, there is a protein ratio is more than 40/1. This is also same in that of acute, that is pre-renal acute renal failure and hepatorenal syndrome. But the resistivity index which is seen by the ultrasound is more in hepatorenal syndrome than in pre-renal acute renal.